And the first two speakers are Doug de Boer and Christina Restrepo. Doug is a professor. Oh. Doug is a professor at the University of Wisconsin, and there are some Wisconsinians here. Excellent, I like it. So not that many, I hear, but and then Christina is a private practitioner in Florida. Any Floridians? Okay, good. So they're going to talk to us about clinical science and also diagnosis of atopic dermatitis. And there they are.
You're a little bit difficult to follow. I'm afraid I can't quite do your dance moves there, but we'll try to come up with something at least as interesting. Well, everyone here in this room and everyone actually in the virtual room here is here at least in part because we see itchy dogs. We see lots of itchy dogs, and we struggle not only with diagnosis, but especially with treatment of these dogs. And part of the theme of this meeting is going to be talking about itch and allergy and pruritus and how we can treat it better, diagnose it better. And so I'm going to kick this off, and we're going to talk just for a few minutes about clinical presentations and diagnosis, just so we're all on the same page as to what this disease looks like. So let's begin then. One of the interesting, unique things about veterinary medicine is that our patients can't communicate well. Actually, we're dependent on this third party to help us discover what's going on with the patient, and that is, of course, the owner. So the first thing we have to do, our first job in any disease, but especially in skin disease, is to have a really good history, to listen to the owner. And I suppose I'm prejudiced, but I think probably more than in any other specialty, getting a good history is really critical to our success in diagnosis. So listening to the client is really critically important. So many of the historical clues that we use in establishing a diagnosis of atopic dermatitis come from the history. Now, one of the things I wanted to mention first is it takes a long time to do a good history. I think probably if you had to sit there and just transcribe it, it might take you 20 minutes or even 30 minutes to take a proper dermatologic history. So one of the things you can really do to help you out, I think the first tip I would give you is make sure in your practice that you've instituted a history form. Send it to the clients before their appointment. Have it available in your front desk. The owners can fill this out while they're waiting. Be a millennial and put it online. Make a fillable PDF if you're really brave, and have it sent back to you. You can review this then before you even interact with the client in the exam room. You can actually have a very good idea of what the patient history is even before walking in the exam room, and then it becomes a 5 or 10 minute process to kind of clarify things with the owner rather than this arduous 20 or 30 minutes. So it's a big time saver and much more efficient. So what are we going to hear? What are we going to get from the history in a dog with atopic dermatitis? Well, of course, one of the first things is going to be itch. My dog scratches. My dog itches. And, excuse me, it may be that this started at a young age. It may be that it was seasonal at first and then progressed. Very often we see the complaint being mostly pruritus on the ventral area, as is shown here, although clearly other things we listen for are pedal pruritus. We listen for facial pruritus, which can be very, very mild, like is shown here, or can progress to the point where the animal can even have some conjunctivitis in association with their atopic dermatitis. So pruritus, very, very important thing. Sometimes, of course, the answer is it's all over. We ask the client, where does the dog scratch? And it's almost easier to ask, where does the dog not scratch? But even in this dog who's severely affected, notice that the dorsum is relatively spared. And that's one of the things we'd look for because, of course, if the dorsum is what's affected, then we think more of fleas and that sort of thing. So listening for those clues of pruritus and where it's located are important. Listening, paying attention to breed predispositions, to the retriever breeds, to the terrier breeds, and thinking, though we know that the skin is the most important organ that we want to talk about. We know that there are other organs as well, and sometimes they can be affected with allergic disease. So we ask about things like gastrointestinal complaints. Has there been borborygmus, intermittent soft stool, intermittent vomiting? In fact, things that the client may perceive as normal. The client may have been living with this for so long with their pet that they think that, gosh, it's pretty normal for my dog to have diarrhea all the time and vomit 3 times a week. But those would be historical clues to us that we may in part be dealing with the food component to the allergic dermatitis. Not to mention prior treatment. If the owner says to you, you're the 3rd veterinarian I've been to, and the other 2 veterinarians have given me some little white pills, and it really stopped the scratching. My dog peed all over my rugs, and which is why I'm here to you, because the last 2 veterinarians made my dog urinate all over. But of course, steroid response is something we listen to, and classically, atopic dermatitis is a steroid responsive condition. So we've listened to the owner. Now our next job is examination and looking at the patient to see what we can see. Now, based upon what the owner has said, we may hear that there's a tremendous amount of pruritus, but it's not uncommon, especially early on in the disease, for there to be very little physical evidence or visual evidence of disease. In fact, a dog with atopic dermatitis can look remarkably normal, yet the complaint is very severe pruritus. And to me, that's almost a giveaway, because if you think about it, almost all of the other skin diseases that cause pruritus, they're lesional from the beginning. Fleas, scabies, Ehrlichia infection, whatever, they're lesional from the beginning. But if you have severe pruritus and the skin looks nearly normal, that's really, I think, a clue. So here's a dog that has fairly mild erythema and inflammation, mostly on the ventrum. Of course, it can get worse and does get worse with the passage of time. It's often easiest to see these inflammatory changes on the ventrum where the hair isn't as dense. And of course, with time, depending on the dog, depending on the breed, how long it's been going on, we get much more severe changes, and we can even end up with something like this, which is a nightmare for us and for the owner. With chronic inflammation, we have to recognize that there may be changes of chronicity, beginning hyperpigmentation, thickening, lichenification of the skin, prominent especially in some breeds. And here I think it's important, we kind of register this and say, oh yeah, that's chronic inflammation. But I think it's important to say to the owner, I think you've probably noticed your dog's skin is turning black, and we want you to understand that that's just chronic inflammation. It just means to us the inflammation has been there a long time. Because what they're thinking is, uh-oh, black skin equals melanoma, is my dog getting cancer? Even if they're not saying that. So I think it's very important to say, don't worry about this. It's not cancer. It's not precancerous. It just means chronic inflammation. Of course, this can get quite severe, as is shown in this dog as well. And the second area we want to look at is the face. Face, ears, eyes, and so forth. We can have everything from very mild facial pruritus, complaint of rubbing the nose between the sofa cushions, especially these long-nosed dogs that the nose very conveniently will fit between 2 sofa cushions, and they saw their face back and forth and back and forth. So facial pruritus, very, very common as well. Around the eyes as well, sometimes to the point where these dogs may self-traumatize, as we know. They may cause corneal damage from their constant rubbing and scratching at the eye area. Interesting, though, that they typically don't have much in the way of respiratory signs. And here you can see another one of our poster children for atopic dermatitis, this French bulldog with very, very severe facial pruritus. While looking at the face, we can't ignore the ears, because here is another clue that we may be dealing with atopic dermatitis as opposed to a different condition. That would be chronic inflammatory changes on the pinna itself. Here we see some mild thickening around the opening of the ear canal. The pinna often becomes thickened and can become hyperpigmented, as shown here. So the finding of pinnal dermatitis is another real key thing that we look for in atopic dermatitis. In fact, sometimes pinal dermatitis with chronic bilateral episodic otitis externa. That can be the only manifestation that we see in some patients with atopic dermatitis. This dog, in fact, has only itchy ears, doesn't have pedal pruritus, ventral pruritus, and so forth. So that's another one of the unusual manifestations of atopic dermatitis. And finally, pedal dermatitis. It isn't always this obvious. Here, this dog has clearly been chewing at his feet and making them red and allopectic. It may be something simple as minor salivary staining that occurs in these cream-coated breeds of dogs. Looking also at the ventral surface of the paw, looking for alopecia, looking for erythema, and I think important to part the toes and look in the interdigital areas, because this is not only a frequent area where dogs scratch and lick, but it's also a frequent area where secondary problems like infections occur, and certainly those need to be considered when we're considering treatment. Well, one of the things we say in dermatology is with atopic dermatitis, often the lesions themselves are fairly minimal, and most of the lesions actually are related to excoriation, to chronic inflammation, and to secondary complications. So examination of the patient for secondary complications. Here, probably the most common, staphylococcal pyoderma, as indicated by these papules and pustules on the ventral abdomen of this dog. Now, as these age, as they rupture, as they heal, we'll get this very characteristic epidermal collarette lesion. The epidermal collarette is simply a pustule that has ruptured and is healing and drying, but is definitely an indication that there's been some staphylococcal pyoderma here. Likewise, we want to consider the possibility of Malassezia yeast overgrowth. Inflammation, a greasy or moist texture to the skin, and especially odor, this odor that can't be washed off, that is often indicative of yeast involvement. So can be very mild, but as the skin undergoes chronic inflammation, again, lots of hyperpigmentation, lichenification, thickening, this kind of elephant skin appearance that can occur in the skin of dogs. And of course, we have the poster child here for this condition, the West Highland White Terrier, here an atopic Westie with severe secondary Malassezia overgrowth. These patients actually can become hypersensitive to their own yeast organisms, which then greatly increases their pruritus and greatly increases our difficulty in treating these guys. So just in quick summary, when we talk about atopic dermatitis, our first two things to do are listen, and that is with a good history with the client. Secondly, physical exam to look for the very characteristic signs of atopic dermatitis. And then the great thing is we have some lists that we can use. We have lists of diagnostic criteria that are very good. They're very helpful for us. And we have lists of diagnostic tests that we have to do in order to rule out things that can mimic atopic dermatitis. So I'm going to, in a second, turn this over to my colleague, Christina, to talk about these lists and so forth. But while we're changing speakers here, I want everybody to consider a question, which is, we've talked about the fact that atopic dermatitis, excuse me, can be related to environmental allergy, but also to food allergy. And this is always, I think, an interesting question and a subject of considerable debate, and that is, how often is food involved in atopic dermatitis-like disease? So let's ask, in your experience, in your practice, and in the dogs you see, how often is itchy skin at least partly related to food sensitivity? So why don't you, we'll answer that question on your smartphones while we're changing speakers, and Christina, we're ready for you.
Thank you. Let's see. Looks like we're an even tie between uncommonly and commonly. Interesting. Okay, I would definitely agree with the commonly. uncommonly is interesting. Oh, they go back and forth now. Excellent. Well, good morning, everybody. So I'm glad you've been able to listen and look. So now we'll focus on listing and learning in order to achieve your diagnosis of canine atopic dermatitis. Can everybody hear me okay? Is that a little loud? We're good? Okay. So let's start. Okay, so our first step in the diagnostic approach to canine atopic dermatitis is really going through your list of differentials. And that's super important. It's why you always hear us focus on looking for secondary infections and looking for demodicosis, dermatophytes, and even things like scabies. And I've included those lists in your notes, but I did want to go over some individual points. I think my finger's clicking a little faster here. So in order to start your workup, you basically want to first focus on sample collection, right? So especially when you have skin lesions, that's your first approach, is to really start looking to see, well, what's at the skin level, so that you can start collecting some samples and in order to go through your list of differentials. So the first slide I'm showing here is collecting or using an impression smear. So that's just a basic glass slide pressed up against lesions. And a lot of dermatologists or clinicians like using this as a primary tool of sampling, and that's perfectly whatever you're most comfortable with, that's perfect. So I prefer personally glass slides or impression smears for very moist or exudative skin lesions. I feel like that collects it a little bit easier. But certainly you can use tape cytology, as you see on the other screen. And I was going to say, yeah, right-hand side. So you can certainly use tape cytology for either more difficult to reach areas, such as the interdigital skin or around the mouth or around the eyes, where it's a little harder, I think, to press a glass slide there. And so here you're seeing samples of that. The other thing to focus on is the nail beds. And so that's commonly an area where I'll find much different cytology from what's in the interdigital skin even. So I'll perform nail bed exudate, or I'll collect samples of nail bed exudate and frequently find too numerous to count yeast, for example. Whereas if I just performed samples of the interdigital skin, all I was finding was bacteria. And so that's a big difference for how I'm going to treat this patient for its secondary infections. And you'll see the tool I'm using there to collect my sample is a medical grade spatula. So it makes me cringe just a little bit to see broken Q-tips or something like that. It's just, there's really no need for something like that. If the dog were to flinch or move or wiggle away, it'd be an easy way to jab them with something like a broken Q-tip. So use something like a medical grade spatula or tape. Tape works perfectly well to just get in there into the nail beds and collect your sample. So by whichever method you've collected your sample, either if that's tape or ear cytology or an impression smear, you're still going to stain your slide. And you don't need to even heat fix your slide. So whatever method you choose, you don't need a heat fix, meaning if you do an impression smear or ear cytology, you just go ahead and go right to your staining technique. And on the right-hand side, you see me folding the tape over the slide. You don't have to do that, but it's just a little trick to help prevent the tape from sliding right into your jar of stain. So that's why we do that. And I typically do run my slides through the 3-stain process of your Diff Quick. If you're using tape, you don't have to use the first stain, which is your fixative. So that can sometimes remove the adhesive of the tape, and that's why it just slides off and ends up in your jar. But you can still use it. It doesn't really matter, honestly. So here we have a beautiful, gorgeous picture of everybody at once. Yay, epidermal collarettes, which I love. This makes dermatologists very happy. So what 3 diseases or conditions do you commonly see when you, or what common diseases are caused by or lead to epidermal collarettes? So absolutely, so bacterial pyoderma. What are your next common ones? absolutely, dermatophytosis and demodicosis. So all of those conditions will lead to an epidermal collarette. So don't always jump to immediately thinking this means you have just pyoderma and nothing else really is underlying that. So in this case, you did have a bacterial pyoderma. So you're seeing beautiful cocci here in little clusters. And then the purple basophilic staining you're seeing behind that, that's broken apart neutrophils. So when you take your sample, the neutrophils, because they're typically going to be degenerative, they'll just kind of break apart and smear. And so that's why they'll see this purple staining. So that's your definition of a bacterial pyoderma. So here you have feet that show interdigital salivary staining. You have brown nail bed exudate. On the ventral aspect, you see a lot of the erythema that Dr. DeBoer was showing you. So what do you think we'll find on cytology with these feet? Yeah, so everybody's quick to think absolutely brown nail bed staining, or maybe they have that Frito smell. Good thing we don't have Fritos for lunch. But certainly, absolutely, we can guesstimate that there's going to be some yeast. And in this case, you would be right. So a lot of yeast here. And so here you're finding budding yeast. That's the bowling pin shaped cells. And I like to show you samples because if you're not comfortable, I tend to think that's the main reason why cytology is not performed as frequently as it needs to be in dermatologic workups. And so if you're not comfortable, the best way to become comfortable is to practice. So the more cytology that you do and the more you see these pictures and these lectures, or call your dermatologist, absolutely, we're always happy to show you samples. This is the best way for you to become familiar and train your technicians, which is very empowering for the technicians to be able to help you diagnose these conditions. But don't be fooled by smells and what it looks like. So in dermatology, really, anything can look like demodicosis or dermatophytes. Or those feet, I have pictures that show nothing but cocci. So again, cytology is crucial to your dermatologic workup. So following along in your steps of your workup, a deep skin scraping is something that we just can't do without. Nothing replaces deep skin scraping. And so here you're showing me prepare a sample or an area of skin that's about 1 centimeter by centimeter. And so what I mean by that is I don't want a millimeter being scraped. And so I want a good area so that you can perform a deep skin scraping. And I warn the owner, I'm going to make a red raspberry. That's how I need to diagnose if they have mites. So I don't really ask them if that's okay. I let them know that that's the process that's going to happen. And so they tend to be okay with that. They're warned that it's going to be a red raspberry and it doesn't really hurt the dog. And you saw me in that sample using a medical grade spatula as well. So again, I try to avoid very sharp instruments if I can. I'm a dermatologist after all, so we don't like excessive blood, except on deep skin scrapings. So here I'm using just basic hemostats to obtain trichograms. So you're just plucking hair from lesional skin, and you can add that to your sample of your deep skin scraping. So you would just lay the hairs flat on your sample along with your deep skin scraping, or you can do it separately, whatever works best. And just you prepare it in the same manner. So you're going to apply a few drops of oil, place a glass cover slip, and you read it just like you would your deep skin scraping. So in very severe cases of demodicosis, just via trichogram, you can see all life stages here. So hopefully you can see even from behind that there's eggs, there's juveniles, there's adults. So trichograms are very useful, but they don't rule out demodicosis. So they're an adjunct tool. And just if I need to collect extra samples from, like I said, the periocular skin or perioral or the feet, it's a great adjunct. And we still, running down our list of differentials, flea allergy is really crucial in diagnosis of environmental allergies, because I need to make sure that this dog isn't mainly itchy on the back half of its body from flea allergy dermatitis as opposed to environmental allergy and having itchiness on its belly, etc. So flea combing is still a very, very useful tool, especially during the exam with the owners. It's much, much easier to convince an owner of flea allergy when you do have flea dirt. So that's always a slam dunk. So certainly use your flea comb, use a white tissue to collect your sample, and just a few drops of water will rehydrate that and prove that they have flea poop on them. Now the trick is always when there is no fleas, and that's actually for me an easier finding to convince an owner. And so because I'm able to say, well, it's actually because your pet is so clean and never has any fleas on them, that's how I know they're hypersensitive. They're allergic to those flea bites. And I like to use for them the analogy of mosquito bite allergy in a person. So if I tell them, if you're allergic to those mosquito bites, I never heard a person say they saw that mosquito get them, but they're not walking around with mosquitoes, but they certainly know that they're allergic to mosquito bites. And so those kind of tips help convince an owner that their dog is flea allergic as one of the components to their allergic disease. Now, if you have these type of shake and bake ear margins, then that starts alerting you to a different differential, right? So this dog would be most itchy on the ventrum, the elbows, hocks, and certainly the pinna. And so when you perform your superficial skin scrapings, you might even see a pinnal-pedal reflex, which I won't demonstrate, but maybe later. So here you have an adult scabies mite. And even if you were to just find one scabies egg, that's diagnostic for scabies. So it's still remember to keep that on your list of differentials that you're working through. Now, I've spent in this workup, although I spent a few minutes, this can take me a couple of months to really go through treating the secondary infections, looking for treating and looking for flea allergy dermatitis and all these other differentials. And certainly over the 2 months I've spent doing an elimination food trial, especially in the non-seasonal pruritic dog. So all of that has led to my diagnosis of, or getting to the point of Favreau's criteria for canine atopic dermatitis. So I'll run through this a little bit quicker. So the first criteria is your young dog, typically age of onset less than 3 years of age. Exceptions would be if they just move from a different state and within a year they start showing typical signs. Or you have an indoor dog mainly, like this California princess. The third criteria would be non-lesional itchy dogs, so very itchy dogs, no skin lesions. That's always a good clue as well. Affected front feet is a criteria for Favreau, and obviously this is a picture that begs you to what? Tape, scrape, and pluck. So let's move on to our next one. So affected pinna is another one of Favreau's criteria. So you see a lot of erythema or the itchy ear canals without infection yet. And you'll notice the pinnal margins are clear, which is another one of Favreau's criteria. And what is this a poster child for? An itchy, rashy rump. I heard it. I think I heard it. So absolutely, flea allergy dermatitis, which is not one of Favreau's criteria. So Favreau wants you to make sure that you have a non-affected dorsal lumbar area. And the last criteria is corticosteroid responsive pruritus. So, and I actually use that quite often, especially when they're referred to me and there has been response to prednisone, then certainly I put environmental allergies a little bit higher. It doesn't rule out food allergy by any means, and it certainly doesn't rule out the common conditions or the common cases that we see, which have a component of both. So they're going to have some food allergies involved, but also mainly environmental allergy. So now that you've gone through your whole differentials, your list of differentials, you've done your elimination diet trial, you feel confident about your diagnosis of a canine atopic dermatitis by having at least 5 to 8 of Favreau's criteria satisfied, which obviously the more criteria, the higher your specificity. now, and only now, will you consider doing some allergy testing, okay? And at this point, you've either already referred and the dermatologist has done this workup, or now you're ready to send your client over with a confident diagnosis and now prepare them in the owners that are willing, and certainly in the cases that are moderate to severe and affected greater than 3 months out of the year at least, now we can do our skin allergy testing. And really my goal in skin allergy testing is being able to choose which allergens are going to go in their allergen-specific immunotherapy. Okay, so again, I don't use this as a diagnostic test for canine atopic dermatitis. To me, it's in order to choose what I use in their serum. In this dog, obviously, we also learned that really only saline is the only thing that he's not allergic to. So excellent. So that's what I have for you. Thank you very much.
All right. Thank you very much, Christina.